Hello and welcome to this IPCRG asthma right care presentation linked to how we best practice in communicating an asthma diagnosis to our patients. My name's Steve Holmes. I'm a general practitioner in the United Kingdom, and I hope during this presentation that you will be able to pull out some useful techniques and methods that you can adapt in your own clinical environment to help to make that communication of an asthma diagnosis more effective, empathetic and clear for our patients. So, as we move forward, what I hope to do during the presentation is to talk about the diagnosis of asthma and why it might be a problem, and cover some of the areas that highlight why it can be a problem both culturally and contextually. I'm going to talk about some of the models that have been described to help to break news. Often these relate back to breaking news for things like cancer, but we all are involved in breaking news of new diagnoses to patients very regularly. Talk about some gentle warnings and simple explanation techniques that we can adapt and use in our own clinical practice, and briefly talk about supporting the patient beyond diagnosis. So that's where the presentation is going to go. I think the first challenge for many of us is getting the diagnosis right, and I'm not going to concentrate on that today, but as you know, the IPCRG desktop helper is a really useful method on the jigsaw puzzle approach to building a diagnosis and building that circumstantial evidence that we have to say this fits with a picture of asthma. How do we make that diagnosis? And that's a fundamental core component of how we then help to discuss with our patient about their diagnosis and management. That's not the purpose of today, is to go into the diagnosis, so I'm not going to do that. But what I am going to do is to talk about the impact of a diagnosis of asthma on some of our patients. And I know that probably a lot of our clinical colleagues say, well, everybody knows about asthma, it's common, there's plenty of treatments about. We hear from time to time about footballers and elite athletes having asthma. Surely everybody understands a lot more about asthma. But I think most of us who've been in clinical practice for a while understand that there are challenges associated with that. If we just move through some of the models that have been used to describe what happens to a person when they are told they have a diagnosis, I think Cecil Hellman's work, described more than 30 years ago now, really laid the bedrock for further development. But what he described was people across cultures want to know what has happened, if they have something that's happened to them. Why has it happened? Is there anything I've done? Is it anything that's happened to me? Why me? Why not others? And why has it come on now? So those sort of fundamental questions come in quite commonly to people as they seek to understand if they have a new diagnosis or new illness. They also want to know what would happen if nothing were done about it. Will it just get better on its own? Will it get worse on its own? What will happen if I don't do anything? And what should I do about it? Or whom do I consult for further help? So that was Cecil Hellman's work back in the 1980s and before. Subsequent to this, Leventhal, about 20 years later, described a more succinct model which says, in a much more medicalised way, what is my diagnosis? What's it called? What's going to happen with this diagnosis? What happens with this disease, this illness that I've got? And what does the future hold for me? Often, again, going back, how did it happen? What is the cause of it? Was it something I did? Was it an infection I caught? Is it linked to my family history? Why how did it happen? And then again, I think most of us, if we have a medical problem, would like it cured if possible, but often have to accept that we may not be able to cure, but we can treat, alleviate, and improve things, both with medications and with the things that we can do ourselves. And that's a really important fundamental, is this isn't all about a diagnosis where we do things to people. The diagnosis has impacts on lifestyle and what the patient is required to do to minimise consequences of their disease. And that goes down to the final point that Leventhal talks about, which is what sort of choices have I got that will make an impact as I move forward? Will these affect my future? And that's often where people now talk about shared decision making, or that collaborative working between a clinician and a patient to make a difference. So what sort of stories and reasons do we hear about at the time where people are getting a diagnosis or suspecting a diagnosis of asthma? And I appreciate it's often not just a one-off situation. This is often something that develops. Within IPCRG, the Asthma Right Care Group, we asked a variety of colleagues from across the globe some of the sort of comments that patients had when they came for that diagnosis and what might be going on. And I've picked a selection of these just to give an idea of the diversity of reasons why a person might have questions about why they have asthma. And I think one of the common things in many communities is, this is going to affect my job. I don't have health insurance. I won't be able to afford the medications that are available, if there are medications. Sometimes the diagnosis can affect people's ability to join a police force, or if they want to join an army, to join the army. Also, a lot of people will worry about their job and being made redundant because the employers might not want people who have lung problems in their workplace. So again, that really causes uncertainty and fear and a reaction about what's going on. Just think about blame as a reason as well. Is it my parents' fault? Is it something I've done to myself? Is it something that all people with asthma are bad people? A lot of people will have reasons as to why they think they've got asthma, and whose fault it may be, or is it their fault? Is it something they've done? So please keep thinking about those sort of implications. Let's move through a little bit more quickly on the next one. But again, I'm a bit worried. If I get it, will my children get it? Will people like me if I've got asthma? It might be infectious. What happens if I pass it on to people? Also, quite commonly, people have personal experience of people within their family setting or friends who may have had adverse outcomes from asthma. And that's worthwhile thinking through as well. And remember the confusion over terminology. Some people use the term wheezy bronchitis or COPD or asthma and a variety of other areas interchangeably. So that clarity about what we mean by the diagnosis we're providing can be really vital. Common one with a new asthma diagnosis is, right, that's fine, I shouldn't exercise anymore now, it's dangerous to get breathless, that's the end of my footballing or scuba diving career. And again, that's important for us to think about how we inform our patients, how we work with them, and what sort of concerns they specifically have. Last little area is often patients in different environments are worried not only about the cost of the drugs, but the impact on them or their family or the planet. And again, a lot of publicity has been going on about how inhalers may damage the planet. Many people are worried about the impact of steroids on the body. And many people are looking for natural and herbal solutions to any medical problems that they have. So we have quite a lot of potential barriers to talk about in that context of making the diagnosis, as we do about some of the treatments that we're likely to recommend and immunisations. So hopefully what we've picked out from this is we cannot guess what the patients, carers, family, friends are saying about the diagnosis, treatments, management, what they're worried about. And that's one of the arts of practice and skills of us as clinicians, is to finding this out sensitively and helping patients to understand in the best way they can and make the right decisions for them and their health in the long run. So let's now move on to some of the models that are described about breaking bad news or breaking medical news. It's not always bad, and I think that often with a diagnosis of asthma, we are looking at making a positive diagnosis that enables the patient to subsequently use their own changes in lifestyle and also to make those changes with the medications available to have a long, healthy, symptom-free life. So let's take this on a positive note. But it's worthwhile noting that many of the models described have been originally based on breaking news about a cancer, which obviously has quite different connotations at times. So let's start with a really basic concept, but some areas we still forget to concentrate on this, which is around ICE, or ideas, concerns, expectations, again described back in the 1970s. Ideas are really important to work out what does the patient's ideas about their condition, what does that mean? Their ideas might have been, I've caused it because I've been bad, the medications are dangerous, it's going to affect my health, I'm not going to be able to play football. Concerns often come into what might have happened with families and friends, financial implications, both affording the treatment, getting insurance to go on holiday, their ability to work, have children, all sorts of areas that they might be concerned about. And equally important is that expectation. And one of the things we know from a lot of the literature around asthma is our patients often underestimate how well they should be when they're on the right treatment. That's been a persistent finding in the literature over the last 20 to 25 years at least. So we need to make sure they have expectations that are realistic and probably are higher than a lot of our patients actually believe at the moment. And when you look at the number of elite professional athletes who have asthma, and that varies between 10 and 20% or more, so higher than the normal population. Perhaps there are reasons behind that. That's a different lecture, I think. But think about if professional sports people who need to get that extra percent to be at the top of their game against other professional athletes are managing this with a diagnosis of asthma, then me being able to run 5k or 10k should not be impossible, or to play sports like other people. So that's the idea of ICE. And I think one of the things that's really important to think about when we're going through these areas is that, and the quote again seems to be attributed to Abraham Lincoln, but the old, young and poor live from day to day. They don't always think about tomorrow. Many of our patients, especially if they are very young, or if they're very old, or they don't know where the next meal's coming from, don't really want to be thinking about the next 40 or 50 years into the future. And that's an important concept to grasp when we're talking to individual patients. Other things to be thinking about, which came under the Becker and Mayman research, was how motivated is that patient, we think, to take control of their own health and get as fit as they possibly can. How vulnerable do they perceive themselves to be with it? And what are they weighing up as the costs and benefits. We may be very clear about how good the treatments are and what the costs the patient might be about that, but they may well not be. Equally so, one of the saddest things we sometimes come across is parents, friends, relatives, spouses, partners who have lost their loved one from asthma and say, I never realised, and they didn't either, that you can actually die from asthma. So important to make sure some of those messages get through. So how do we go about that? Perhaps the first thing on this is to look at the research done in around 2000 called Spikes, set up really to help clinicians talk about breaking bad news, but what they talked about was setting up a private, comfortable space where you can speak to the patient. It shouldn't be done in a busy ward or when there are lots of people wandering around or in a corridor. Make sure you've got that little bit of time and comfort to allow the patient to be able to concentrate. They talked about the perception, understanding the patient's ability to understand what language are they using, what is their educational background, what have they told us already that helps us to understand what their likely expectations are. And then they talked about asking for information about what the person wants to know, how much they want to know, and what would they like to know. The Spikes model talks about giving a good, clear information in plain language, sometimes using a warning shot. Now that's often used more in cancers, but often if the asthma diagnosis is not going to be taken comfortably, it's sensible to think about a warning shot. We've been doing some tests and we've been looking at some breathing problems there. Have you thought about any potential conditions that you may be thinking about at the moment? We'll often highlight any concerns the patient has, but also give you another opening to be able to use to then say, no, it doesn't sound particularly like cancer. This is sounding much more as though it's in one of the treatable lung conditions called asthma. One of the other things we might do is, if they use a term like, well, I was thinking about wheezy bronchitis, say, that's very good. That often fits in with what some people term this. Most of us now medically use the term. So you've got ways of moving that knowledge into a way that they can probably understand. And then that important bit of information is we can get them to be able to source some of the information themselves, get hold of information that helps to make a difference. Next thing that Spikes talks about was managing and acknowledging and validating emotions and empathy. If you suddenly find out you have a long-term condition, that can have quite substantial impacts on your future plans, your future interests, and will provide quite a lot of anxiety and difficulty in understanding where you want to go with it. So do expect emotion, and sometimes that emotion can come over quite aggressively. Finally, on the Spikes model, they talked about at the end making sure that you go back carefully and summarise back to the patient and check their understanding. Now, you can actually get the patient to summarise to you. So tell me what you think we've been talking about today. What are the key points you've taken away from this today? And if they're saying, thank you, I know we've been talking about a new diagnosis of asthma. You've told me why. I've got that with the test that we've done, and I can see that now. I know that I've got to start to try and keep as fit as I can and think about some of the immunisations you discussed. And you've also spoken to me about the safety but importance of using some of the medications. Then my job's done. If they're not quite sure of the diagnosis still or coming out when they reflect back to you, then that can be quite a useful way of, again, just making sure you know what you're going to discuss next time, but also clarifying things there and then. What other models are there? There was the ABCDE model, advanced preparation, build a relationship. And again, all these I think do make sense. Communicate well, deal with those emotions and encourage emotions are all very important as we go through that advanced preparation, reading the patient's note, as well as that good place to be able to have the discussion. And patient rapport is really important. Us understanding the patient, where they're from, and having a professional interest in their well-being often means that the discussions are a much easier source than if we're seeing them for the first time. We've got a limited amount of time, it's in a busy clinic, and we've just got to get through the work so we can get home at 5 o'clock. Breaks, produced in 2010, again covers very much the same sort of models as we've had in Spikes, but sort of covers again background. And I think this one highlights quite nicely the importance of us as clinicians having an in-depth knowledge of the patient's problem. Asthma, it's not something that you want a clinician who doesn't know a great deal about that to talk about, because you need to be able to discuss the subtleties, the nuances, the important areas that the patient is going to ask you about, and that's much easier if you know the condition well. That depends on our expertise. Rapport fits in with what we've spoken about already. Exploring, again, fits in with what does the patient know about the condition? What can I base my discussion with them on? If they give nice little stories about a clear understanding of asthma, my parents had it, my sister's got this, one of my children have that, I'm just not quite sure why I've developed it now because it is the same symptoms, then we have a good place to know what else we might need to explore. The other areas, again, around making sure that the announcement, knowing that they do have asthma, some countries and areas use slightly different terms for asthma, but it's important to make sure they understand what the problem is and accept the emotion, understand that, and empathise with that sort of emotion is really important. So across those, we've talked about core models, preparation, keeping it patient-centred, using the best jargon-free language we can, acknowledging emotional reactions and being empathetic. And perhaps the final one that's really important with all these models is making sure that we give hope and actions that our patients can do as they move forward. So let's look at some of these little bits in a bit more detail. The professional environment is very important, and the time to have read notes, to have looked at the appropriate tests, and the time with the patient to make a difference. And I know in different clinical settings globally, we have different lengths of time with our patients. We have different lengths of time available to read notes beforehand. And I think most of us will have been in a situation where we think, I wish I had more time with my patients, or I wish I'd had more time to read the notes beforehand. Ideal, let's do the best we can with the resources we've got and optimise the way in which we communicate in that sort of scenario. Similarly, that building a rapport is really important, and the things we know about building rapport often fit around being empathetic to the person's concern, trying to address the person's concern, and listening actively. What can be very frustrating for us if we're speaking to somebody, and to our patients if they're speaking to us, is if we ask a question and then we're tapping away looking at something else and not really listening to what they're saying. So make sure there's active listening. And I'll tell you a little bit more about that just so we've got that clarified. Nice little quote from Socrates, a very early doctor, talking about the nature giving us 2 ears, 2 eyes, but 1 tongue. And that listening and hearing and seeing is really important. And I just want to spend a moment reflecting on what is active listening. I think the first thing is, and I'll giving an example again, you can see a picture of a dog there, head tilted, ears alert, eyes looking. The whole of that dog is looking to listen to what's going on, not just the words that come out, but the actions, the movements, and the way in which the words come out. Think about, and probably the scenario I use fairly often is in inactive listening, is if two people are watching a football match on the television and someone comes in and says, do you think it's time to do the washing up now? Many people will not really hear that, won't have any great interest, and will just sort of try to even avoid communicating about it. They're not listening to what's coming in from that side because they're concentrating on the football. The next area to think through is selective listening. And if you think about the football analogy again, the two people watching the football, somebody comes in and said, would you like a cup of coffee or a drink of some sort? That selective drink, yes, I'd like a drink, might well come through quickly, whereas lots of other comments that might come into the room at the time when they're watching may be missed. We know that some patients will use words that they've learnt to attract medical attention, chest pain, breathless, because they know the clinician will perk up if we mention chest pain or we mention that we're unusually breathless. So that's selective listening. We listen to all the words, but some words spark more interest. Reflective listening is often where we're trying to clarify and convey mutual understanding. So it's when it's a complicated issue, going back and adding a few comments into our patient. Tell me a little bit more about that. You said this. Whereas active listening, like the dog, is a conscious effort not only to hear the words, but to understand the message, and it includes non-verbal communication as well. And that's where we're actually pens down, concentrating on our patient, listening to what they're saying, being intent, listening to what their concerns are. That gets us a long way. So, few of the other areas that are worthwhile just thinking through as we move towards the end of the presentation. One is around the purpose of pre-warning, and that's to try to make sure we reduce the shock. If we really just launch straight in and say, hello, sit down, I'm here today to tell you you've got asthma, patients are going to be, I wasn't expecting that. People often need a bit of time. They will often have been thinking it through before they come in, but some of those triggers saying, yes, it's sounding as though it is going to be, is allowing them to re-assimilate and keep in control. The sudden, no warning hit has exactly that impact. It causes much more shock. The clear language and empathy we have touched on already, and I'm not going to go through that anymore. But again, it's trying to avoid medical jargon, but it has to be understandable and it has to be reproducible so that other colleagues are using similar medical language as well. I think one of the things that's really important when we think about sharing decision makings is we want the patient involved in that decision. We need to listen to their preferences, understand them, active listening, and we need to get the best from those, because that will improve the satisfaction of the patient and it will improve our clinical satisfaction and the results the patient gets. And one of the important things to think about with that is, as professionals, we have to work with our patients to get the best outcomes for them. Sometimes they can be wondering if perhaps we have different agendas. Perhaps it isn't. We might be wanting to give them drugs because we get more money if we do that. Or if we can do more tests or make more diagnoses, we might become richer. So it's important to make sure we're really professional about letting them know where we are and what our situation is as well, so that we can work with them to make what the decision's best for them. And that might be slightly different to the decisions we would make if it was us. always useful to keep that patient hope going. And again, with most of us, if they can get hold of treatment, we can be saying asthma should not be a life-limiting condition, and we hope that you will be able to do as much as anybody else who doesn't have asthma in terms of activity. In fact, we want you to do more, because the more active you are, the better you eat. The fact you're not smoking will make you healthier than most people, and that will keep you in a much better condition throughout your life. So keep it positive. Also, think about the inaccuracies. We don't want to be too paternalistic in saying, no, you're wrong, no, you're wrong again, no, that wasn't right either. What we should try to do is build on any inaccuracies they have and try and move them into a more medically accurate model, so that it helps them to understand and improve their knowledge, and also their trust in us, that we're not going to just say, well, you don't know what you're doing. That respect we're giving them will not only enhance their motivation and also their trust and acceptance of what we're saying, but will reduce their anxiety as well. Final few things to think just slightly outside the box. Remember, this isn't a regurgitated list that we can give to the patient. We spoke about that at the beginning. They have lots of different ideas that they're coming in with. I'm no artist. Sometimes I try and scribble down and then look horrified at the images I've tried to draw for a patient, but some of my colleagues are really good at doing that. A lot of us might use visual tools to help, especially in people whose language and literacy isn't that great. And again, in many of our countries, we welcome people from many different cultures for which the home language may not be their easily understood language, in which case interpreter support can be invaluable. And part of our skills at that time of diagnosis, and part of our skills moving forwards, having established rapport, are helping to support the patient as we move forward. And that may be a variety of different things that help them to improve. The first one being customised written materials or digital information resources. And of course, there's a QR code on here that you can access for more information in this sort of area, which we hope you will have a look at and use for the people that it fits in with. So this is tailored information. It's not, I'm going to give them all the information I possibly can. It is information that's going to help that person and their situation to get the best out of it that they can. Some of our resources are on here, and I've left the QR codes available for a little bit longer so you can access those. But the big thing behind that is these are information that are often generically available in many areas. That's good, but we also need the local support networks and follow-up services and community support. So in many areas there are asthma support groups. In quite a few there are community resources that can provide extra support and education. And we as healthcare professionals can provide timely follow-up to help that shared pathway as we move forwards. So don't forget the local networks as well as the national plans and resources available. So finally, before I come to the last slide, just worthwhile thinking, I normally say when I see a patient, hopefully that's given you information you can work with. Here are some resources that you can go to have a look at that might give you some more information. Let's meet up again. What do you think? Perhaps in X amount of time. And please, if you do have any questions, write them down. I'm here to answer your questions and work with you to get the best we can from where we are. And that sort of use of language can sometimes help our patient to say, yeah, they're interested in me. They're also interested in the questions I have, not just telling me what's going on, which is the easy solution. So, effective communication, really important. Preparation important. Make sure we get that communication right. Cultural sensitivity ensures the communication respects and adapts to the patient's background and beliefs. Really important for all of us. And finally, ongoing support helps to build on that trust and encourages the patient to be a shared partner in the management of their asthma. I thank you very much for listening and hope that you will be able to use some of the other IPCRG resources from Asthma Right Care to help in what is often a challenging clinical environment, but we can make it easier for our patients and for ourselves. Thank you.